Good morning, everyone. Welcome back to Mount Sinai. This is the first installment of our 2025 Treat Live Symposium. I wanted to welcome everybody here today, and I want to also thank our AV support, BroadMed AV, for their world-class AV support in this endeavor with us. So before we start, I wanted to introduce our special guest today. Dr. Parag Patel from Medical College of Wisconsin is here on the line. How you doing, Parag?
Doing well. Thanks for having me.
Good to see you. I think we have a really cool case to discuss today, and we really want to hear your thoughts. So without further ado, we're going to head over to the lab, room 1. We have Dr. Lookstein, Dr. Patel, and Dr. Kulkarni here. I think they're going to present a really cool case for everybody. So let's get started.
Welcome, everybody. Can you hear and see us?
Loud and clear.
All right, perfect. So Aaron, thank you. Parag, thank you for joining us this morning. Good to hear your voice. Parag Patel is a very, very close, dear friend of Mount Sinai IR. We're broadcasting now from room 1 here at Mount Sinai Hospital. And just by brief way of introductions, to my left is our superstar fellow, Sid Kulkarni. And to Sid's left is my obviously close partner, Rahul Patel. We have a fascinating case we're going to share with you this morning. Before we get to the case presentation, I just want to take a moment to thank all the staff here that allow us to do this every month. We have just amazing not only technologists, but nurses, our anesthesia support team. Everybody's just put together a fantastic effort this morning to allow us to share this fascinating case with you. So again, from everybody at Mount Sinai IR, thank you to all our support staff. And then without any further introduction, I believe Sid put together a very, very brief case presentation to get everybody up to speed, and then we'll start the discussion about how to optimally manage this case. Sid, go ahead.
Thank you. Good morning. My name is Sid Kulkarni. So today we have an interesting case of uncontrolled hypertension in a young patient with Takayatsu's arteritis. Go to the next slide, please. So he's a 33-year-old male. He has a history of Crohn's disease and newly diagnosed Takayatsu arteritis. He actually presented to the emergency room last August with hypertensive urgency, where he had a CTA chest, abdomen, pelvis, and it showed circumferential soft tissue density or thickening around the abdominal aorta and his common iliac arteries, suggestive of a large vessel vasculitis. He also was noted to have complete occlusion of the SMA and severe stenosis of his bilateral renal arteries. He's being currently managed medically for his hypertension. He's taking labetalol 200 milligrams BID, amlodipine 10 milligrams daily, as well as clopidogrel 75 and aspirin 81 daily. He's actually a nurse, and he checks his own blood pressure regularly, and he reports his systolic blood pressures in the 140s to 150s at home twice a day, even on 2 antihypertensives. When he presented to our office hours, it was noted his blood pressure at that time was 123/73. His physical exam was largely benign. The one notable finding was on auscultation of his abdomen. You could actually hear a bruit at the level of his umbilicus. His creatinine 0.84 was normal, but he had elevated ESR and CRP. He's also 6'4", which comes into a little bit of decision making later on when we decided how to approach this case. Next slide. So here's the initial CTA. You can play this video. This is just an axial in the arterial phase as we scroll through the abdomen. And we can see there's kind of stenosis of the proximal bilateral renal arteries. And we also noted he has 2 accessory renal arteries on each side for a total of 6 renal arteries. It was also noted that he has severe stenosis or complete occlusion of his SMA with collateralization of the distal portion. Next slide. Go to the next slide. So here's the sagittal just showing that proximal SMA occlusion with the flow in the distal portion. Go next slide. Here's just some close-up pictures. On the right, we see his two main bilateral renal arteries with pretty severe stenosis of the proximal portions, as well as soft tissue thickening around his abdominal aorta. And he had a renal duplex, which showed elevated systolic velocity in the proximal renal arteries bilaterally, up to like almost 2 to 300. Next slide. So in assessment, he's a 33-year-old male with Takayatsu arteritis, leading to bilateral severe renal artery stenosis and uncontrolled hypertension. Still has elevated blood pressure on 2 antihypertensive agents with 3 bilateral renal arteries. So we're here today to do a bilateral renal angiography with possible stenting. And we opted to go for a transradial approach. And that's why we were discussing his height to make sure we actually have enough length to get down there.
Sid, thank you for that presentation. So I'm just going to, if we could cut to the camera to show how we're set up here. We had a long discussion about this, and I'm going to talk a little bit about the decision making about how to manage this patient clinically. But if you're able to show this, so what we sometimes do if patients are very, very tall, his actual fingers are right here where my left hand is, where I'm tapping, and you can see our access is, probably a good 10 centimeters up his wrist. So we did, not a true, distal radial artery. I would say a more of a mid to distal renal artery, just to give us an extra 10 centimeters, and that allowed us to place a 5/6 slender radial sheath here, and then we have a 6 French 100 centimeter FR4 guide cath, and we're planning on doing our interventions based on that. Before we start to sort of get you up to speed on what we've done so far, just from my summary point of view, we have a patient with a large vessel vasculitis involving the entire infrarenal aorta. It's manifesting itself as a significant inflammatory occlusive disease of several renal arteries that's clinically manifesting as refractory hypertension. He has severe disease in both of his iliac arteries, and while he's, subjectively mildly claudicating, he says he's not able to do what he normally does in the gym. That's not his primary concern right now. He also has a complete occlusion of his proximal superior mesenteric artery, but you'll see momentarily he appears to be well collateralized. And when we interviewed him in the office during our intake initial consultation, he expressed no symptoms of chronic mesenteric ischemia. He felt he was able to eat adequately any kind of diet. He was not losing weight. He had no postprandial pain whatsoever. And so I'm chalking the visceral occlusive disease into the asymptomatic category. Again, I'm going to open this up. Aaron, Parag, how would you approach a patient like this? Before I sort of hand it off, I just want you to know that since we saw him in the office and he had relatively mild elevation of his biomarkers, he's been put on a very aggressive immunosuppressive protocol. And his most recent biomarker assessment, which was about 2 weeks ago, showed that all of his biomarkers, which demonstrate the inflammatory process, were essentially down to 0. So we view him right now, and he has been for about 2 weeks now, successfully medically treated. So we are not treating any active process. He's not had side effects from his immunotherapy. So we feel that he is well managed from that point of view, which is why we scheduled him for today on a elective, semi-urgent basis to be able to manage some of these clinical manifestations. And so again, I'm going to throw it out to you guys of how you would approach a patient like this in your clinical practice. Parag, what do you think?
Yeah, I'm glad you mentioned that last point there, because I was going to ask, when are you determining when a patient's in an active inflammatory state or in a quiescent period, or perhaps optimally medically managed? In that really active inflammatory state, I don't think that's the ideal setting to manage these endovascularly, typically, unless it's an emergent scenario and you really, you have life and limb at risk. This is a symptomatic refractory hypertension patient, related to this, medically managed. So that's great to hear. That was the first question I was going to ask, but you've already addressed that. So I think the timing, anyone can do a renal intervention, to your point, but it's what about the timing in these patients? A little different than an atherosclerotic patient. So that's one point, but you've addressed that. The other piece here is, unique anatomy. You've got bilateral accessory renals, multiple on each side. And is it just, and it looked like some of them might be sizable. So I'm curious, how are you determining which ones to treat? Is it just the main renals on each side, or are you going to determine, am I going after multiple? At what size are you going to determine this is one I should go after, or maybe leave it be? Because I suspect that's going to be something you're going to address on the table today.
Great question, and I'm going to try to introduce you to what we've done so far off camera before we went live. I guess one of the first questions I'm going to ask you is, would you address the iliacs if the patient's presenting with mild symptoms in the same setting, or would you just focus on the renals? I think that's a initial question, and then is it your practice to do, for example, one renal artery at a time, and to stage it, or to do a so-called global revascularization? I think that's a good topic for conversation.
Well, you went radial, and so I think you'd have to go out of your way to treat the iliac. If you were going femoral and it was causing you problems to access, it might make sense to go ahead and intervene along the way. But having gone radial and he's a claudicant, while we know treatment of significant aortic occlusive disease certainly help claudicants, I'd say focus on what you hear. The task at hand, his biggest issue is hypertension. I'd focus on the renal arteries and then there.
Rob, what's your
obviously,
Rob, can I ask you a quick question before you move?
Sure, go ahead. Go ahead.
This is obviously a different case because it's non-atherosclerotic, but what's your experience in multiple renal arteries and atherosclerotic disease and stent? Do you find that if you leave one artery that has disease in it, you're going to end up with a minimal impact on the blood pressure?
Obviously, we're not liberal in terms of our approach to renal artery revascularization. We're relatively conservative, and I think there's broad consensus about that, which is in line with the recent hypertension American Heart Association guidelines for renal artery revascularization. So we really look at this as so-called failure of medical management, and for a 30-year-old, I think even being on 2 antihypertensive medications and running with an ambulatory blood pressure, ambulatory systolic blood pressure greater than 150, I would say that's a failure of medical management, especially with these imaging findings. The patient does not want to be on a third agent, is concerned about the side effect profiles of the other agents. As we expressed, he's in the healthcare profession, and so he was really seeking out an option for revascularization at this young age to try and alleviate these symptoms. In terms of staging it versus non-staging it, I think our approach has significantly changed since we've adopted a sort of radial first approach for this. I think when we were going femoral, there would be concerns about either downward facing renals or multiple renal arteries with challenging access and different shapes that you would need. But since we're going radial, I think the access is really alleviated completely with a guide from above, and so we've taken a much more, I would say, comprehensive approach to renal artery revascularization. We plan on correcting, I would say, every abnormal renal artery that we find this morning. So to that note, let's get you up to speed on what we've done so far. If we could go to the angiographic images. This is the first run that we did, and we had a Serra catheter, 5 French Serra catheter down in the visceral aorta, and obviously there's a lot of findings here, but I think most significantly is you see the main renal arteries that have moderate to severe narrowings on both sides. You see a very hypertrophied arc of Riolan coming off the inferior mesenteric artery, which reconstitutes the superior mesenteric artery distally through the left branch of the middle colic. You see relatively moderate narrowing of both common iliac arteries with a questionable dissection of the right common iliac artery. And then again, you see a fairly large left accessory renal artery right about the level of the origin of the inferior mesenteric artery, and then probably one vertebral body above that you see an accessory right renal artery. Next run, please. This is just an oblique, which I think just gives you a little bit better holistic view. Of note, there's very small accessory renal arteries, probably on the size of 1 to 2 millimeters, that are supplying both lower poles of the kidneys. We can talk about that, about whether we should even interrogate that and whether there's a durable endovascular option for that, whether that can be a contributor to renal vascular hypertension or not. We're probably not planning on coming up with a definitive approach for that this morning, but it's certainly a worth conversation. Next run, please. This was the first artery that we interrogated, which was the accessory renal artery on the left, and it looked pretty normal, as you can see. Can we go back to the previous IVUS run, if that's possible?
You want the first one?
Yeah, the first one. As is a routine for these patients with either vasculitis or FMD, we do intravascular ultrasound, and I think you can see this. Can you see the IVUS, Aaron?
Yes.
Aaron and Parag?
Yep.
Yeah.
Very,
So
very
the
nice.
IVUS is basically normal. And we did a translational gradient, but that was normal also, and it corresponded with the IVUS very, very well. So that artery is obviously not something that we're going to treat. It's normal angiographically and by IVUS, which I think is the gold standard for this type of case. Next run. We then focused our attention over, that was just a pressure wire in. We focused our attention next to the accessory right renal artery, and there we have a wire in the accessory right renal artery there. And again, I think we did IVUS at this point.
Yep. That's it.
And this was a very, very, sort of, I think, good teaching case for intravascular ultrasound.
Can we show the IVUS, please?
Are you guys able to see the IVUS?
I can see the angiogram. Then now we see the IVUS. Thanks.
Okay, yeah. So we're going to play through this. This is a pullback. And you start to see that the vessel becomes just obliterated very readily there. And what's interesting is that it's really an intravascular process. This is something that's involving the renal artery here. It's not an extrinsic process. It's not a compressive process from the aorta. It's really an intravascular renal artery process. We did the same thing with chromaflow. And again, you just see it very nicely obliterated right there. That's probably the best image that we have. So again, just a really nice example of the inflammatory changes we're seeing in the renal artery. We also did FFR, and you can see we were measuring an FFR of 0.7 and a very, very significant translational gradient, and you can see the gradient there on the screen. And we were able to successfully revascularize this artery. We actually used the IVUS to measure it, and we placed a 5 millimeter stent. And I was going to ask you, Parag, if you measured the normal artery at 5 millimeters, what kind of implant would you put in?
So did you measure it at 5?
Yes, we measured the artery distal to the stenosis at about 5 millimeters.
Not bigger, just at 5. I guess the 5's fine.
Yeah.
I think, if it was a little over 5, I would have gone with the 6, the light inflation, but I think 5 is my smallest I'll go. These are pretty good size accessories. This is the accessory, and the other small ones I think are too small to treat, but I'd love to hear what your thoughts are on size criteria. My concern is when you get smaller than 5, stent patency becomes an issue, and then do you start using, drug-eluting stents for something smaller? But 5, I think, is fine. You got a good luminal gain here. I don't think you need to do anything, different than what we typically do in a lesion, atherosclerotic lesion that looked like this.
Rob, did you say what stent this was? Was this a DES or
yeah?
Or bare metal?
So we didn't say that yet. So I was going to just ask you, Parag, about whether or not, given that it's a 5 millimeter normal diameter, 5.0 diameter distally, would you put in a bare metal stent, a drug-eluting stent, or a covered stent?
No, I wouldn't put a covered stent. I haven't. We've moved to a lot of covered stents in the SMA, or in iliacs and CTOs. But my renals, I tend to like uncovered. And then the question is, if I'm getting a standard 6 or 7 millimeter stent, it's traditional 014 platforms and bare metal stenting. When I get smaller, stent patency becomes a concern, and I've gone to drug-eluting stents. The only options typically are going to be our coronary stents. So, but we don't stock those. We have to grab them from our coronary lab, and they don't do a lot of peripheral. So typically a 5 isn't something we're going to always have available. But if I think that's where I'm headed, I'll have to bring that in.
Got it. So in this case, for this branch, we actually placed a 5 millimeter coronary stent. Obviously, this is an off-label use for this, but to your point, and I think you are absolutely spot on, that we do get concerned about patency. This is a very, very young patient, and so we chose the Megatron variety, which has a proximal reinforced cellular matrix. For osteo lesions. It's been our sort of go-to for small diameter renals for the last several years. And in this case, we put in a 5x12 Megatron. And obviously, I think you can see it was sized perfectly. We actually took it up to about 5.4 millimeters just to oversize it slightly. But that's where we are with that. We then drew our attention up to the main right renal artery, and I'll just direct you there, and that's where we are right now. And I'm going to basically go live with the intravascular ultrasound so we can see and talk about it. The working wire that we're working with, and I might have mentioned this before, but we have an FR4 6 French guide. Our sort of workhorse wire for these kinds of cases is a 014 coronary wire. It's called Stabilizer. It's distributed by Cordis currently, and it's just a very, very soft atraumatic tip with a very short transition. And I think it's a very, very safe wire to do renal and visceral work on. So if we could go live to the IVUS, I think that would be great. Are you guys able to see the IVUS yet?
Yeah, we can see it, Rob. I'm going to ask a question while you're doing this. So, I mean, this is
go ahead.
We're sort of well past this, but the audience might be wondering: is there a role for angioplasty alone in these types of non-atherosclerotic lesions, or do you think there's not really a scenario where that would be beneficial for this patient?
So we're crossing the lesion right about now, and I think you're going to start to see, right there, pretty significant narrowing of the renal artery, right? But both you guys can see that?
Yep.
We can see it very well,
And then there's the normal renal artery, all right? And so I'm going to do a formal pullback and record it.
Ready?
Yep.
Record.
And here's the pullback. And we will actually measure the artery off camera, but you see that's the ostium right there. So it's very, very narrowed and obliterated. And on the reconstruction on the side, you can stop recording now. You can see that again. It's an intraluminal process. So can we measure the distal renal artery? And Parag, we'll take that into consideration, what diameter that we're getting, and we'll decide what kind of implant we're going to put based on that.
By eye, it looks
Aaron,
it looks a little bit bigger than the other accessory.
I agree with you,
by eye,
and it's a really good question to have, which is what's the ideal implant for this kind of case?
If I had to guess, Rob, this is probably going to be a 6
to Parag. Yeah, and again, we can talk about what that should or would look
7
like. So
there.
we're getting 6.3 times 7. So again, I'll ask you, Aaron, and you, Parag, what do you think we should put in? Should we put in a 6.0 bear? Should we put in a 7.0 bear? Obviously, there's no such thing as a 6.0 or a 7.0 drug-eluting. We could be very conservative and put in a 5.0 drug-eluting. I also agree with Parag. I don't really like the idea of putting covered stents in the renal arteries yet, especially because it's a 035 platform, and I get concerned about spasm with that. But this is what we're finding. I personally have not felt that angioplasty is durable in this setting. I think that's not going to be a durable result. I can almost set the clock now about how soon this patient's going to bounce back to have a repeat intervention if we just do angioplasty. I think stenting's the way to go here.
So it looks like you're between a 6 and a 7. We might. There are some stents that are available 6.5, 5.5. You've already placed a drug-eluting stent, so the decision to put somebody on an antiplatelet agent, even though I think he's already on Plavix, right, Rob?
Yeah.
Yes.
Yeah. So I would say I would say I'd be fine with either. I probably would lean towards the larger stent and not post-dilate it much bigger than 7. That's sort of my bias here. What do you think, Parag?
Parag, what do you think?
Yeah, I think it's 6.3. So if you go with the 6, you're gonna have to post dilate this to 6.3, 6.4. I suspect you have that max diameter at 7. So it's quiescent. I always worry about these inflammatory patients but you have a stent there, so you're not doing a balloon dilation where you worry about dissection. I think you're gonna go, if you're going with the 6, you're gonna deliberately post dilate this a little more. If you're gonna go with the 7, you're gonna be very gentle and probably try to minimize how much you post dilate this. So a little bit of you can go either way here. What's the length here? You probably don't want to cover too much either.
It's very, very, very short, right? So I mean, if we're gonna put in something, we're putting in either I'm gonna probably make an executive call to put in a 7. And he's a tall patient, as I previously mentioned. He's about 6'4" in height, so I think he'll probably accommodate a 7. I don't think we're going to take a 7 to burst pressure as you stated, but I think if we take a 7 to nominal, I think he'll accommodate that very, very well, and I don't think it's going to be an issue.
Yeah. So Rob, just out of curiosity, so the Megatron is 5. How far comfortable would you feel over dilating if you really wanted to put a drug?
Yeah, I think we've spoken about this issue, about how extensive you can take these 5mm coronary stents before the polymer starts to fragment, and that's the overall concern, right? Because if you don't get a uniform, reproducible drug delivery, and you can really map out the pharmacokinetics of the anti-inflammatory or the anti-proliferative agent, you're really sort of just rigging a drug-eluting stent to behave like a bare metal stent. So that's not going to help anybody. And from what I've been told, you can take a 5mm polymer-based drug-eluting stent up to about 5.7, 5.8. You really can't take it up to 6 until you start to get polymer breakdown. That's the sort of transition point, and it depends on the manufacturer that you're choosing to partner with about whether or not you're going to have really significant polymer breakdown or just moderate polymer breakdown. Some of them will say it can handle it up to 6, but in my experience, if you're over 6, it's probably not a good idea to put a drug-eluting stent in.
Is that the shortest one we have? Okay, 7.15.
7.15.
All right.
You're also gonna with the bare metal you're gonna be able to go to 7 and even a little more if you wanted to. You're probably not going to need to in this case, but you're sort of, the difference here is, like you said, at least 1 millimeter, and this is an inflammatory process, and so you're gonna probably have some concern, especially in a younger patient, about in-stent restenosis, and we don't really know the answer to that question, whether drug-eluting stents really help long term in these patients. I mean, I don't think we have. I mean, unless I missed it, Parag, I don't know the answer to that question. And I think in a case like this, the larger diameter is probably going to give you the most bang for your buck, despite the fact that you already used the DES in the other vessel. But I think size.
Yeah, I don't think we have a lot of
data
for.
Yeah.
I don't think we have a lot of data for Takayasu's and renal intervention in general, right?
Yeah.
So obviously, this large vessel vasculitis is not our common clinical patient. It's one of the reasons we thought this would be a very, very good teaching case and a whole educational process for everybody who follows us. We certainly do see a lot more athero and a lot more FMD than large vessel vasculitis. But it is a part of our practice, and I would say we see somewhere close to a handful of patients every year that have a large vessel vasculitis, and we try and do our best to manage them. This is obviously a very, very young patient, and it's a healthcare worker, and so we want to do what we think is the best thing for them to make sure that they can return to work and take care of patients. And so we don't have all the answers. Just as an aside, if you look at the global demographics, where most of the patients with large vessel vasculitis in this age show up. It's in countries where they don't have the resources or the experience to be able to use, for example, drug-eluting stents. And sometimes they're not even using, 014 dedicated, renal stents either. So we're using our best judgment, and we're trying to do what's best for the patient here to make sure that they have a very good outcome and, God willing, a very durable outcome.
Parag, is there anything that you would do differently in a setup like this if you were going to do femoral access? Would you be using the monorail system, or are you guys thinking about other potential stent platforms or wires or anything like that?
No, so I think there are a lot of similarities with setup here. It's the same platform as Rob had mentioned. I have not transitioned to 035 systems in renal intervention, so I do prefer an 014 setup. They tend to be monorail. I'm going to either put a sheath or a guide catheter to the orifice here. I'm generally coming femoral, although I've done both. The only change then would be if I felt like the angle wasn't favorable, I'd either go radial or I'd use a spherical sheath. But otherwise, outside the sheath, which is related to the angle of the renal artery to the aorta, the rest of the setup, wire and balloons and stents are similar. I like this.
That looks
By the way, the comment on anticoagulation, what have you guys done for that?
So we gave 3,000 of heparin through the radial sheath, and we gave an extra 2,000 of heparin. And we're actually not going to check an ACT here. We're just trying to move very, very quickly and be done shortly. I think we agree this is a good place for this renal stent, or do you guys want it in a little bit farther or back a little bit farther? Parag, are you happy?
I like it. Is this a 723? What do you have here?
This is a 715. And you can see the stent's almost occlusive. The nominal pressure is 11, and so we're going to take it up to 11.
Yeah, it looks like it's centered perfectly there.
It's 11. 11.
Yeah.
All right, it's probably enough.
Yeah. So that's what we were talking about. Go to profile on a bigger stent's probably better than having to go back in with another balloon.
Yep.
And we got to really make sure we deflate this, because this is probably the largest balloon that we can deliver through this guide. So why don't we manually take this down?
Sometimes when we deliver these balloons. Sorry, go ahead, Rob.
No, I was just going to say that these are 070 guides, and a 7mm balloon is about the largest device that you can deliver through this, which is just important to note. And so we get very, very meticulous about manually deflating it to getting it out. And obviously, I think you saw that. Sid manually deflated it, really collapsed. It was very, very snug. And we're going to, obviously make sure we don't lose the wire when we're doing this exchange here and setting up for a follow-up angiogram.
It's a good point, because that type of balloon release is that's probably not going to be the case with a sheath, right, Parag? I mean, a guide is going to be a little bit tighter. From the radial, the guide cath is the best way to go, I think. We do have long sheaths, but they're not typically angled. So you could theoretically use a fully hydrophilic sheath, a 6 French from the radial, and do this case with a sheath, but you're not going to have the angulation on the sheath that you would get with the guide catheter. So there's a lot of benefits of using this guide catheter. Rob, you mentioned that this was you said this was a 110 or a 100 length guide? Because it looks like
it's
a little bit is hanging out.
It's a 100 length guide.
Okay.
Yeah,
so he's not actually not that
guide.
He's not that tall, unless you access much higher on the wrist than I saw.
All right. So I really like that placement for that stent. Obviously, I don't think there's any concerns that we missed the lesion. We didn't cover the adrenal artery. As a routine, do you guys think we should re-IVUS this or redo an FFR, or do you think we should go to the other side and try and wrap things up?
Well, I think I want to see you stent the other side, but I would run the IVUS personally.
Okay. That's fine. All right, we can run the IVUS. All right, let's wipe it down. We're gonna go back to IVUS so we can just make sure that that's being shown live.
Okay, flush it.
Obviously, we're all set up and ready to go with IVUS, FFR, and with DSA.
Parag, what wire do you use for
Table side
renal
IVUS.
intervention?
I use an 014, like I use a Spartacore, certainly a working wire, obviously. I mean, your coronary platform wires are great. To deliver a sheath, sometimes I've used tapered wires to get a bigger sheath up, because an 014 wire isn't always going to be stable enough. So, you know, just the old TAD2 wire that tapers down to 018 if I want to deliver a sheath. But frequently I'm working over something like a Spartacore.
Yeah, the atraumatic wires are very important in kidney intervention. There are several situations where, especially in difficult cases, where you have to switch to different wires, including, fully hydrophilic glide wires, and those can be an issue in the kidney for sure.
Yeah, it's long. There you go. There you go. All right, so here we go with the.
We're gonna cross now with the IVUS. Yeah, I mean, it looks perfect.
Good wall
Yeah,
position.
looks good.
Can we record now, and Rahul will do a formal pullback?
I think the 7 was a
You
good
all
size
can
here.
see this, right?
Looks
Yeah.
great.
I think we have really good wall out position. I'm very happy, and again,
You can stop.
we're projecting into the aorta about 2 or 3 millimeters, and so if there's any concern about overgrowth, then obviously that's going to be mitigated. So
Oh, we can take the wire out, right?
yeah, we can take the wire out. So
Yeah.
we're done on the right side. Now we just need to take a look at the left main and be able to get in on that side. And then
So the
we'll
great
go
thing
through
about
this whole
this
same
angled
exercise.
guide,
We'll measure everything.
I'm sure you're gonna do this in a second, but you're gonna probably be able to take that Guardian, turn the knob quickly to the opposite side, and then send the stabilizer, maybe with a little puff of contrast, right into that left renal, and that should work really well. So what you can do is have one operator puff a little contrast on the side of that guide, as the other operator sends the wire across. That's usually what we do.
Sometimes you just need a better operator.
Well, I mean, there is this is probably not going to be super challenging to cross, just because it's not occluded, it's not atherosclerotic, but there are scenarios where we would potentially use a buddy wire system, where you take a better crossing wire and then send that over secondarily. But obviously, you
as usual, Rahul makes it look very, very easy.
Ready?
And again, you can see a pretty tight narrowing, and I think we're just going straight to IVUS again.
For maybe it's just me, but it looks a little longer, the stenosis on this side than the opposite side.
It's probably going to be the same. Again, if I had to guess, the post-stenotic area is pretty wide. And again, it's why I think IVUS is so helpful here, to be able to make sure you're choosing the right implant. If I had to guess, just based on looking at this angiogram, we're probably going to end up using a 715 again. If you look at the stent, we put it on the other side, corresponding, it's probably going to be the exact correct length. What's also amazing, and I think you're all appreciating this, is the arc of renal land coming around again at the end of the angiogram, which is just so fascinating. But again, the patient's completely asymptomatic from a mesenteric ischemia point of view, so we are going to leave that alone, because we don't treat asymptomatic patients.
All right.
So I would probably agree with your guess that it's going to be the same stent size on this side. It just looks that way to me. But I mean, obviously we could go smaller. But would there be a larger stent here that we would consider? I'm not even sure that this product comes above 7. Does it, Rob?
Can we record, do a pullback? Thank you. And so you guys can see the IVUS, right? And then you see the same obliterative process down there. All right. Can we go back and do a measurement off of the distal artery? I would say right there. Can we measure that? Right there. Yep.
Looks a bit similar. Does this stent go above 7, Rob? Do you know?
So this stent is not commercialized for larger than a 7 millimeter diameter. But as I think you're all aware, because it's a balloon expandable stent on a semi-compliant balloon, If you take it to 17 atmospheres, it will enlarge to approximately 7.5 millimeters.
Yeah, so I think that's a really good point. You know, if you pick the right stent size, you should be able to do the entire angioplasty stenting with one device and not have to switch balloons. I mean, it's not a big deal to switch balloons in cases like this, but it definitely creates a bit more work, and multiple exchanges just increase the likelihood that you might have an issue. What do you think about that, Parag?
Well, that's saying 7.7. Is that right? Minimum?
Yeah, it
diameter?
is, but I don't think we're
Can I
gonna.
can I have another?
It's a little
7 by
ovoid
15,
shape the
please?
way it was measured, right?
Probably go with the 7.15.
Yeah, I still would go with a 7 here. You could maybe take it up more, but I don't even think you would need to. I think going to 7 would be fine.
Yeah, I mean, the one concern if putting in a 7.15 is if you do have to overdilate, it's going to shrink on you, right? So that's one thing to take into consideration.
So we're actually going to try a 7.18
Okay,
and see how that fits in.
Yeah. Do you think? I mean, this is just sort of a theoretical question, and maybe Parag has an insight on it. If you're deciding between, let's say, a 7.15 and a 7.18, do you think that there's a difference there? And because there's really not a branch vessel that we're concerned about in the renal artery here. Do you think it increases the likelihood that you're going to get some sort of longer segment in-stent restenosis, or it just probably doesn't matter that much?
Not really. It's 3 millimeters, but what I like about the 18 is there's a chance you're going to want to overdilate this potentially, even with the same nominal balloon, more than you did before. And if you had to go back in, to Rahul's point, you can anticipate a little bit of foreshortening. This to the eye looks like a longer lesion. I think ultimately the pullback shows it's probably not, but it is a big vessel. So you're going to use all of that 7 and probably a little bit more. And I think the 18 is probably the way to go.
Yeah.
For that reason, I don't think the 3 millimeter like changes your opinion.
I think once we dilate it to about 7.5, it'll probably end up being a 7 by 16, if I had to guess, or pretty close to a 7 by 16. So it's probably going to end up being the right size here.
So there's a little bit of a technical point that I think you guys are sort of showing here, but we haven't discussed yet. So that when you're advancing the stent, you're putting the guide catheter pretty deep into the vessel and not leaving it back in the aorta, which is, you could see there how it was just a little bit snug getting across that stenosis. That definitely helps with pushability, particularly with these monorail systems and these 014 wires. You definitely lose pushability, especially when you're coming from the wrist. So having the guide catheter a little bit further in as you're advancing the stent, and then you can always pull it back as you're doing here.
Ready?
Mm-hmm.
A little bit further.
That is actually, I like that a lot, actually.
Okay.
No, I really like that. I think that's perfect.
I think it's pretty good. I think Rahul wanted to pull it back 1 millimeter. I could tell.
I know. I saw that look on his face, and I said, I really, really want it there. All right, we have an idea of where we are.
Yep.
Do me a favor, just inject it again, Sid.
Yep. Just get some more contrast.
Rob doesn't believe I didn't pull it back while he wasn't looking.
So these stents work great, and one of the things that I've noticed about inflating these stents is they really stay exact, almost exactly where you put them. I mean, I don't find that they move a lot forward or backwards as you inflate them. Do you have any comment on that, Parag?
No, I think that's fine. The comment being, obviously, if you have your sheath buttressed up against the stent too much, the little bit of the shoulder of the balloon could push your stent forward or back. Right. So it's more of a technical thing, not because of the design of the stent per se. So that's just more of something to keep in mind. You might bring that back, a centimeter clear of the trailing end of the balloon, so that when the balloon inflates, you're not inadvertently stabilizing the sheath and pushing your stent forward. But I think you did a nice job there. Just take a look and see how it's looking.
So let's talk a little bit about the follow-up for this patient. So the patient's already on aspirin and Plavix and a couple medications for blood pressure, I think 2, correct? Do you remember, Sid?
Yeah, he's on. I think he's on labetalol and amlodipine. So he's already on two
So
antihypertensives.
if the patient was not on Plavix, would you know, we place one drug-eluting stent here, but not three. Let's say they were on, they had 3 bare metal and no drug-eluting. Would Plavix be a consideration here, or no?
Yeah, I think I would
Ask
still.
that again, Aaron.
If the patient wasn't on Plavix, would you add that after these stents? And the second part of the question would be,
pull it back too fast,
does it
though,
matter if it's bare metal or
stuck at the tip of
drug-eluting
the
in a
balloon.
case like this?
Oh, I would say as a routine, I would want somebody on dual antiplatelet therapy for for any kind of inflammatory process for at least a month. I think with the added issues of the anti-proliferative agent and the polymer, it's probably going to end up being 6 months. I don't think there's any evidence to show that it needs to extend past that. But we're planning out of the gate that this patient's going to be on dual antiplatelet therapy for 180 days.
Okay.
I mean, shouldn't he be on it for a while? I knew because of the dissection.
I don't know that we need dual antiplatelet therapy for that. I think single antiplatelet therapy is enough. But I'm more concerned about just making sure that we get good endothelialization of these stents.
Right.
Mm-hmm.
Yeah, I agree, Rob. That's what I would do. Regardless of the DES, I'd still put him on a dual antiplatelet for at least a month.
Kind of not pointing at it, right?
Yeah.
I think you're just a little above it there. Yeah. What about the blood pressure medications? Or when you want to see this patient and look at their blood pressure?
We do not. Yeah, we do not modify it. I actually like that a lot. All right. So we do not modify the blood pressure at all. Blood pressure medication. This is again a very, very compliant patient, and we are going to obviously speak to them tomorrow. We're going to speak to them next week. We're probably going to do a formal office visit with a baseline duplex in about a month. If anything changes with the patient's blood pressure status, if they start to drift into the more hypotensive range, we'll start to remove one of the agents. I'll probably end up, opting to remove the beta blocker initially, and we'll drive it down. Most of these patients with a systemic vasculitis, we manage in a multidisciplinary format with our colleagues in vascular medicine who have just been incredible partners here with us at Mount Sinai for the last 20 years, as long as I've been here. But we're very, very comfortable sending our patients home with their baseline antihypertensive protocols, and then we just manage them fairly rigorously, usually with a remote or virtual format, just to monitor their blood pressure that way. We make sure that all the patients that are referred for renal artery revascularization have a home blood pressure monitoring cuff, and so they're able to keep a journal and monitor it. And we obviously keep in touch with them on a regular basis to make sure that they're, again, not getting too hypotensive, and that they have a very, very open mechanism to communicate with us, and we're able to monitor them and then modulate their antihypertensive protocols in close to real time.
There's a kink in the IVUS catheter.
The obvious concern is that if we start to discontinue medications on day one, that the renin response might not be realized for several days, if not several weeks.
On the IVUS, please?
And so we might have a hypertensive crisis, which we don't think is really an acceptable option for these patients. So we would rather have them a little bit on the low side than a little bit on the high side.
I'm sure you're going to do a pullback, but that looked great going across.
Yeah. Can we press record?
It's a really phenomenal result. Very quickly stenting 3 vessels.
It's really good on the ostium. I'm probably aligned to leave this alone for now instead of extending it distally. There's possibly some stuff going on distal to the edge of the stent. I'd prefer to see if the immunomodulators can help stabilize that instead of sort of going after it and just putting more metal inside. But I think this is a good place to leave this patient. And again, I think we did a very, very aggressive, global revascularization here. Parag, I'm just going to throw this out as a sort of closing question. I think you saw in our initial diagnostic angiogram, we probably have 2 or 3 millimeter accessory renal arteries going to the lower poles on both sides. Do you have any comments or experience revascularizing those small renal arteries? Should we interrogate them, angioplasty them? We do have 2.5 millimeter coronary stents. Any thoughts about that?
I have not typically chased after those that small. Now, there are rare instances where that might be the culprit issue, but I think you had 3 significant stenoses in 4 of the major blood vessels supplying both kidneys. I think you've done a really great job. I'd be surprised if either of those 2 are contributing major factors to this patient's hypertension, and I suspect he's going to do quite well with these 3, and I would let him be.
Yeah.
I agree. I think right now probably it's not less is more. I think we did a lot of work this morning, and I think he's going to benefit from it. But I think trying to be more aggressive is probably not in the patient's immediate best interest. So any closing thoughts? I think we're probably going to wrap this up. But just any last questions before we let you all go?
I think that was a great case, Rob. I don't have any more questions.
Questions per se. We talked about the post intervention med management, and maybe we could briefly mention when you're going to see the patient back in follow-up. Did you say the timeline typically?
Yeah, so I will routinely, for any renal visceral revasc, I'll see the patient physically in office hours at about 30 days or 4 weeks, and then we get the baseline renal artery duplex. That will be their surveillance baseline. So we'll be able to measure the velocities in all the renal arteries that were revascularized and then follow those moving forward. We will typically do phone calls at 24 hours, 72 hours, and then usually at 1 week following the index procedure, just to again check on their blood pressure and to establish the modicum of communication by which they can communicate with us to see if their blood pressure is changing radically in the short term. But the first physical visit's going to be at the 4-week time period.
Perfect. I think it's good to end on that, to at least close that out for the audience, as to obviously doing the intervention exquisitely is a good thing, but obviously following up to make sure the intervention is going well for the patient's clinical problem is just as important. You guys did a great job. I think the IVUS exquisitely shows a lot of the lesions that you wouldn't appreciate as well on angio. Being able to do this radial and using that guide catheter to select each really well, expert operators for sure. It's really, really great to see this. I enjoyed it. Thanks for having me.
Thanks, Parag.
Parag, thank you so much. Thank you for joining us, and everybody who logged in, thank you. And again, most importantly, thank you to all the staff who helped get this case going on this morning and helps us every day to take care of our patients. And lastly, BroadMed AV, thank you for such incredible production on all of our cases. You've been great partners.
Have a great day, everyone.
Take care.
Thank you.